Hello, everyone. It's Stacy Dillon and Lowell Dillon from Connecting to Cure Crohn's and Colitis, and we're here with Dr. Marla Dubinsky. As we mentioned, we were going to have her do a talk, and we collected some of your questions, which she's going to answer. So I'm going to introduce Dr. Dubinsky. She's the Chief Pediatric of Gastroenterology and Nutrition, the co-director of the Susan and Leonard Feinstein Inflammatory Bowel Disease Clinical Center at the Icahn School of Medicine in Mount Sinai Hospital in New York. So let's hear what she has to say, and then Lowell's going to ask the questions that you guys sent in.
Yes, we have gotten some questions from our mailing list emails. People have emailed us some good questions for Dr. Dubinsky.
She's going to.
Yeah. Should we start over?
No.
Huh?
No, go ahead. It's fine.
I don't.
Okay. Well, why don't I start by sort of updating everyone on what's happening in the world of IBD as it relates specifically to COVID. I've done a couple of different sort of media or virtual updates over the last few weeks, and I'm happy to bring you the latest and greatest numbers so that everyone is up to date on where we are. Just as a reminder, when this all started, we wanted to get together a global registry where we would collect information from a lot of different countries as part of an international organization of IBD. And obviously, a lot has changed over the last 5 Fridays. 5 Fridays ago, we had our first international call. And at that point, things had just started up in New York and in Washington. And we brought our friends our colleagues from China, from Hong Kong, as well as Italy, because that's where we were really going to learn from at the beginning. And a couple of interesting facts about Asia, or at least where it all started in terms of the IBD patients. When we asked our colleague from Hong Kong, she actually told us that there was no IBD cases in patients, no COVID in IBD patients in Hong Kong, which we thought was very interesting. And then there was a study that looked at IBD patients, specifically in China, most notably in Wuhan province. And what they did is they actually isolated these individuals quite quickly. And therefore, the rates of COVID in IBD patients was extremely low, sort of pointing to the fact that isolation worked. It was one of the first things that was done, actually, to say, how do we deal with this? So that's where really isolation came into play. But most importantly, many of them stopped medications, and unfortunately flares were happening. So we learned 2 very interesting points right up at the beginning, which I'm sure will lead to some of the questions, which is, should I stop my medication? What happens if I'm on a medication that I remember my doctor telling me it may affect my immune system? And so we've learned a lot that actually keeping patients in an uninflamed state is probably the most important part of managing IBD in this scenario of COVID. So I think we got a couple of really interesting messages from the very beginning. And of course, as it's evolved, our registry has grown. I remember last week there was about 530, and now we have updated information that as of 4/22, so as of yesterday, there are 704 cases in total of 39 countries, and 227 of those 704 are actually from the United States. And the second in behind the US, not surprisingly, again, if you follow the numbers, and I'm sure we're all watching the numbers closely, next in line is Spain. And these are, again, cases of IBD patients with COVID, and then Italy. And so it's very interesting to see that the numbers of patients in the world, IBD or not, are obviously highest in these countries that I just noted. And therefore, don't forget that the numbers are going to follow wherever there's a higher incidence of COVID. And particularly, not surprising to anybody, that of the 227 in the United States, that the bulk of those patients, 83 patients, are from New York. And again, we've got a lot of IBD patients in New York. We have a lot of, as you notice, New York City has a very big burden of COVID. As a matter of fact, our hospital, just the Mount Sinai Health System, had essentially almost 2,000 patients with COVID in the hospital across our systems. And thankfully today, there was a message that we're down to just under 1,500. Now that is still a huge burden and still remains a significant problem in New York, obviously, but the ship is going to be leaving, the Comfort ship, and the Javits Center is now down to under 200 patients. So it looks like our health system alone is actually going to be able to manage the current system, but we've got a very long way to go before, at least in the New York area, before things start to get back to any sort of new normal. But the point is, when you dig into these patients, one thing I think IBD patients need to understand also is that IBD is a younger person's disease, right? So it's not like there's that many patients who are above 60, 70, or 80. Those patients that you've been seeing on the news, the elderly patients or patients with advanced age, may have a harder time managing with COVID. So IBD patients, there's going to be more young people of those numbers that are in the younger age group. Again, just follow the numbers of where IBD happens and follow the numbers of where there's most cases of COVID, and the two of them together give you that list that shows you where, in what state, more patients are seen. But when we dig in really into the data and talk about how do patients do with COVID, I think it's very important to also note that only 31 out of 704 patients were under the age of 19. And also we looked at our percentage in our hospital, and actually less than 2% of patients are pediatric onset. So the numbers, again, will follow exactly what the numbers you're seeing in IBD, in COVID infected patients who don't have IBD. Again, nothing is really different about COVID and IBD in terms of risk factors. Age remains a risk factor for patients having to need to go into the hospital, for example. And what's very interesting is one of the largest risk factors for patients needing to go into the hospital and potentially the ICU is really corticosteroids such as prednisone. And unfortunately, what this does show us is that patients whose disease is managed with steroids and not with biologics, for example, which is sort of counter to a lot of what people would think, is that, wow, if you're on a biologic therapy, that puts your immune system at risk, and it's probably safer to be on prednisone because I've been on that before. And the truth be told is that uncontrolled inflammation and steroids at higher dosing were actually a problem, and patients would have more more symptoms and less mild symptoms, shall we say, with COVID in patients who were, again, age was a problem and steroids are a problem. So I think this is not a new story for us. Forget COVID. We've always said that patients need to be on more effective therapy, that corticosteroids or systemic steroids, we sometimes call them, prednisone, for example, this is not referring to something called Entecort or budesonide, which is sort of a locally acting steroid. That's not what we're talking about. We are talking about prednisone. And for the over 2 decades that I've been doing this, I've had the same message. Steroids are more immunosuppressive and associated with higher risk of infections than any biologic one of our patients would go on. And that's a message that has never been more clear than in this situation. And so I think often we talk about the risk and benefits of the biologics, and there's a lot of very legitimate concerns about the safety of these therapies, and they're not in any way saying that there's absolutely no risk to them. But I think the exchange for having uncontrolled inflammation, and particularly the need for chronic steroids, I think sort of is really front and center here, that is not an effective therapy for IBD patients, and patients need to understand that they are riskier than any therapy we'd be offering a patient, particularly in the realm of biologics, and most notably the most common therapy, which is something called Remicade or infliximab or Humira or adalimumab. Those are the classes of therapies, as you know, which we call them anti-tumor necrosis factor therapies. And they're, interestingly, in the COVID story, again, the most of those patients with IBD and COVID positive, more of them were on anti-TNF therapy. Not because anti-TNF puts patients at risk, but it's the most commonly used biologic in the world. So again, follow the numbers. If it's a commonly used therapy, you're going to see that being more often present in patients, and it doesn't mean that that's putting IBD patients at risk. As a matter of fact, the individual, the physician, Dr. Mark Feldman, who first, discovered the use of anti-TNF in immune diseases, first starting with arthritis, and then obviously we followed into the IBD space. He had an opinion in Lancet and wrote an article that said, it appears that someone may want to look at using anti-TNF treatment to treat COVID. Why would he have said that? What is it about potentially the role of anti-TNF therapy at being able to maybe reduce some of the inflammatory, what they call the cytokine bursts, which are those inflammatory mediators that are sort of in patients with really severe COVID lung injury, that there's a lot of inflammation throughout the lung tissue. And there's a suggestion that one of the cytokines, when this cytokine storm scenario, is tumor necrosis factor. Similar to patients with IBD, one of the most common cytokines in the gut of patients with inflammatory bowel disease is tumor necrosis factor. Same with the joint, same with the skin, which is why these drugs are really approved for multiple indications. It's because when you go to an area and you're looking for inflammation, you will find tumor necrosis factor. And the interesting thought is that maybe in patients who are on anti-TNF, they're actually protected from more severe disease related to COVID. Similarly, there's another therapy called Stelara or ustekinumab, which is a blocker of a different cytokine, two actually. One is interleukin 12 and the other one is interleukin 23. And it was interesting that as we look through patients with IBD who are on biologics, and we were looking at what was the type of disease patients with IBD and these meds, what was their COVID course, right? Did they have more mild disease? Were they hospitalized? Everybody, of course, at the beginning. And I think the reason why our colleagues in China were stopping therapies is we didn't know how this virus was going to behave. I mean, there was nobody who knew back in, if we start back in the Wuhan province where this was all happening, no one knew what being on Remicade would have meant, to the COVID virus. And so that's why they were really pulling people off immunomodulators or medicines that may lower the immune system. But then we started to realize and think more about, we even went back to the SARS situation that we had. And there was even people who were trying Remicade in a SARS scenario because the same concept of these cytokines being in the lungs. So we sort of pulled in some information that had been looked at during the SARS timing, and people started to realize that why are IBD patients who are on these biologics, why are over 85, close to 90% of them mild outpatients with COVID and IBD? Is it because they're younger? That's possible, right? Their age is younger. As I noted, age definitely is a protective factor the younger you are. But more importantly, we started to put some science together and say that maybe the reason is because these therapies will sort of dampen, that respiratory or that cytokine burst, and perhaps it is worth looking at the fact that we shouldn't be stopping our medicines. If anything, we should make sure that patients are getting them on time. And that's sort of what we ran into with home infusions. And this has been, I'd say, if someone asked me what was the largest operational change when it came to IBD patients, especially in New York, given our very high patient population. And we were up doing sometimes 85 IBD infusions a day. And patients were needing to be transitioned to home infusions because people who were at college were getting it at college, and then college, ended and they had to come home, and they didn't live in the city. It was the biggest, I'd say, logistical change, the logistics operation of IBD was we wanted to make sure patients were not missing their infusions. And we were doing everything possible to make sure that patients got their infusions on time. because we didn't want patients to flare. We didn't want them coming to the hospital. That's the last place we want to bring them is to the emergency room when it was, at the height of the hospitalizations. I mean, we were having some days where the admissions were obviously more common than the discharges, and we had to surge patients to outside of the hospital. The last thing we wanted to have is an IBD patient having a severe flare, a bowel blockage, or having a severe colitis flare in the ED being assessed, right? So that was really where we started to really say, we need to keep patients on their medications because steroids appears to be a problem, and having uncontrolled inflammation is not a good place for the body to be from an immune perspective, and we didn't want the body to be at risk of getting the virus, So that, I would say, is really sort of the summary of where we are today. It has been an unbelievable month and a bit, particularly in New York area, and to try and understand what is actually putting people at risk with IBD. The good news is it's generally young people, right? That is really the good news about also this situation. But also, a good news is patients should not be stopping their medications if they're not COVID positive. I should state that I'm not sort of saying, yeah, get your infliximab or Remicade, I know you're COVID positive. Let's take that away from, you'll ask me, I think, some questions about what to do when someone is COVID positive and in contact, and we'll get to that in a minute. But a really important message that we have been perpetuating at a global level is if you are not yourself infected or you have not been in contact with anyone who's known to have COVID, you must not miss your medications. It is probably the most important time to be staying on your medications, which is and to get off steroids. That is our other big mission, is anyone who's on steroids because they were weaning, for example, we're increasing the rapidity of getting them off steroids. And even at some points, if we did have severe flares, we were going straight to our biologics and trying to avoid steroids at the beginning of the epidemic. Mm-hmm. So it's very interesting how we've learned so much, which is only going to be, it's only, to me, good outcomes for IBD patients. So I figure maybe I'll be able to address some of the key key sort of nuances of this in questions.
Well, one of them, going back to the question about the biologics, one of the questions we had was, should patients on biologics continue therapy if they might have COVID based on symptoms, but having not tested positive, or if they have been shown to be positive for COVID? Well, is there a point where they should stop biologics, basically?
Right, good question. So as a reminder to everybody that biologics stay in the system for a long time, meaning it's not like a pill where in a couple of days the pill has been completely, if you don't take the pills, they're out of the body really quickly. Those are something called small molecules. But biologics, the reason why we give certain drugs every 8 weeks, it's because it's in the body for that 8-week period, right? So it's not like you're going to be able to stop it, what happened 4 weeks ago. But what is important is for the physician to be made aware. What our general consideration has been, if you have been in contact with somebody and your infusion or your injection is due within a 14-day period, right? Because that's that period where you watch someone during those 14 days after they've been exposed to somebody. So what we would do is if their infusion was due in 14 days, we would check in at day 13, see if they ever got symptoms, see if they ever even subtleties like loss of sense of smell and taste. We've had a couple where they had a headache for a day, lost their sense of smell, feeling fine otherwise, but their parent were COVID positive. I'm giving you examples of what we're seeing in the more mild, especially the kids in the house. And so we check in, we make sure they would no fever, or haven't had to take Tylenol to control a fever for about 72 hours, which is sort of the general recommendations. 14 days since the onset of symptoms, 7 days without symptoms. We sort of have really worked around sort of the guidance, and knowing that everyone talked about that 14-day period. I think that's where we stick the most to. So what I would say is, as long as they've passed the 14-day period and they're not symptomatic, even if they have exposure, then we're carrying on with the therapy, as long as we talk. I mean, it's important to communicate always with your physician, and be able to, there's teams that are still working. I can tell you in New York, we are all remote. The physicians are either working, deployed to the hospital COVID floors, pediatricians, radiologists, everybody was deployed into teams, but we kept back a core team to manage all the telehealth, all the home infusions, everything sort of, it was sort of business as usual for most, actually, on the outside, but on the inside, we had to completely restructure the way that we're providing care and being able to be available, because the most common MyChart message, if you're able to use the online portal or any email to your doctor's office or phone, was at the beginning was definitively, should I stop my medication? We would say, do you have a known COVID contact? When is your last infusion? When is your next infusion? Are you on steroids? Are you on Remicade or Humira plus 6-MP or methotrexate, for example? Because that is one thing, Lowell, that we can do, is actually, unless for some reason someone must be on what we're calling combination therapy, where they're combining a biologic with a non-biologic, we are making every attempt to stop that second drug. Because if you look at Remicade and Humira alone, patients did much better than if they were on Remicade or Humira plus 6-MP and methotrexate. Very important that I make that distinction.
Yeah, that's good to know.
And that's just about drug levels. Yeah, because that is like, that gets lost a lot in translation, the role of combination therapy. And I think that one thing that I like to educate around also is that biologics go after what the cells are making, right? But drugs like steroids and 6-MP and methotrexate, they actually sort of go after a wide variety of cells that you need to fight infection. So those are more immunosuppressive. A lot of people misuse terms, in my opinion. There are drugs that actually lower the cells that are available to fight infection. Those are called immunosuppressives, and and that is a fair comment. But on the biologic side, we're really modulating and we're targeting only those cells that are secreting those types of cytokines, right? It is not going after every cell in the body, unlike steroids go after bacterial, fungal fighting, viral fighting. 6-MP, Imuran, methotrexate tend to go after a lot of more on the viral cells, which is why we're saying, if someone's on combination, and unless it's going to really create a big problem for the IBD itself, we're pulling that second drug. Obviously, it's all context, right? It's one thing for me to say I'm pulling it on everybody. It really depends. Are they pregnant? Do I need to keep them well to get them through their third trimester? You have to, again, weigh every single scenario differently. So, Lowell, if the biologic was administered already, not much you can do, right? Because the drug's in. You monitor closely, wait for those symptoms to be resolved if you're positive, or wait that 14-day sort of contagious time frame to see if you actually get it.
Okay. I guess we'll end with.
What do you ask them?
Oh, okay. Well, so question about the medication, Lialda. The question reads, my son is taking Lialda to keep his UC in remission. Does taking this drug increase the risk of a bad outcome if he is infected with COVID-19? We are assuming that since Lialda suppresses the immune system, it will leave him more vulnerable, and we are taking additional steps to isolate him. We need to know if we should continue to take these steps, as we have been getting conflicting stories. So the question is about the medication Lialda.
Yeah. Okay. Yeah, great question. One thing I want to mention, that IBD itself, because at the beginning they were talking about patients with immune conditions and immunocompromised state. I should tell you that we are not seeing IBD and COVID common, right? So I just did want to state that up front, that IBD itself is not a risk factor for COVID, because that's another important point. With regarding to Lialda, Lialda is absolutely 100% not even close to an immune suppressant. basically it's an aspirin derivative anti-inflammatory that has absolutely no impact on the immune system other than coating the inner lining of the colon essentially to protect the barrier and creating almost like you take a baby aspirin a day to prevent something. It's sort of Lialda is sort of within that frame, but isolation is just because you should self-isolate whether you're on Lialda, whether you have IBD or not, right? Those are the CDC guidance. That's irrelevant to Lialda, irrelevant to IBD, irrelevant to anything. So those CDC guidance will remain in place regardless of what medicine you're on. But Lialda is the last thing you need to stop because it has really no impact on the immune system. And the last thing we want is someone flaring off their Lialda and then needing to go on prednisone, right? So that comes full circle to what we said at the beginning, which is this is the last time to even stop any therapy that even has the word immune something in it. That is really an important message to propagate with your viewers, and to understand that certain drugs, particularly the Lialda family, which there's a lot of meds that is like 7 or so different meds that fall into this, what we call mesalamine, or 5-ASAs is another word, that patients who, thank God, are able to do well on those therapies, they're the last person to stop their therapy.
It seems like you answered a lot of the questions in the talk, except for, what about this question, number 5 and then number 8? Well, there was the question about the hydroxychloroquine. You can pronounce it better.
Sure.
Hydroxychloroquine.
Which I guess
That's okay.
is what we found out about. I mean, it seems like it's been proven to not really be effective in treating COVID patients anyway, since this whole thing started several weeks ago. So that was one of the questions that we had about, could it benefit people with IBD in particular?
Right, it's interesting. At the beginning, when we started all this, and there was a lot of buzz because just like other hospitals, hydroxychloroquine was put into the protocols within the first week of going, our hospital really starting to put protocols in place. And because there was a French study that, by the way, was retracted because of the methodology, which is a very interesting whole other topic about where science is, how important it is to do these trials, and sort of a observation or clinical experience in an uncontrolled setting doesn't always end up being positive. And that there were side effects in patients like heart problems that were happening with hydroxychloroquine, and the idea was that it was maybe causing more risk than benefit. But the concept of using hydroxychloroquine does somehow circle back to IBD, because in essence, patients with IBD, and if hydroxychloroquine is an immune sort of entity, right, it's sort of adjusting or modulating the immune system, it makes sense that some of our therapies, which modulate the immune system, may be helpful and not harmful. And hydroxychloroquine, its side effect profile, it's nothing to do with what it particularly targets. It's more about the drug itself and other things that it does other than just our going after our immune system. But I think that is a message to everybody, Lowell, that using a therapy like that, which meant people wanted to go after the immune system, right? They wanted to modulate the immune system. That really ties into, again, the discussion that by sort of down regulating or keeping the body at a sort of balanced immune state is beneficial, especially in IBD patients. And it doesn't look like our medications, except for, as I noted, age and prednisone, and possibly combining the biologics with an immune suppressant such as Imuran 6-MP, azathioprine, metho. These are all the names that these drugs go by. So I think it sort of made sense to go after the immune, pathways. But as Stacy noted, the bigger studies are not proving that is a positive outcome. Although I saw that there's a study being done for healthcare workers to see if taking hydroxychloroquine, the other name is Plaquenil, sorry, is the other name, is that using it to prevent, to see if it actually prevents healthcare workers from getting COVID. So maybe they're saying instead of treating, maybe it would be okay for prevention. So that's an interesting thing to stay tuned for. I'm not sure what that's going to look like. It's just starting now.
Mhm.
I think you should ask anybody.
Well, I'm sure a lot of people are wondering how to, at this time, how to be handling normal, like doctor visits and procedures, going to hospitals, a lot of doctors, some clinics and hospitals, or, just generally getting a procedure done, like colonoscopy, stuff like that. How should people be?
Yeah, good questions. I'll start with outpatient visits. We in New York are still at staying home until May 15th. And again, in Georgia, as you know, you can get a makeover if you're interested and you need your hair done. But I think that, or massage, or get your nails done. I may just go visit my sister in Georgia. But I think that the reality is there's this has done an interesting thing about IBD care, which we've never really capitalized on telehealth. Just so you know, it wasn't sort of, we always want to examine our patients. We want to see our patients. We love to see our patients. It's sort of what makes us happy is to see everybody doing well. And essentially we had to, probably 500 visits a week, we had to convert to telehealth since mid-March. So our entire IBD center, which is one of the largest in the country, is actually entirely telehealth. So that's been an interesting sort of transition of care. And I think what it will do is, I think we'll go into a more hybrid type, this is my opinion about how we're going to do outpatient IBD care. And I think telehealth, particularly with our nurse practitioners and dietitians and other parts of like the allied health professional team and our sort of multidisciplinary team, I think we'll be able to do, and we'll actually implement more regular follow-up using telehealth after we've seen the patients who are sick. If they need an urgent, we can do a telehealth. Otherwise, they come to the clinic. I think it's going to be a hybrid. It's very interesting. We actually did a survey yesterday to see what everybody thought, what it was like before COVID, during COVID, and what's our prediction of how telehealth will be implemented after COVID. So I'll have an answer for you as to how then the new normal of telehealth will look. But I think for me, it's been great I just like to see my patients during this time. They like to see me, making sure that everybody's okay, everything, it's that, even though we're not in physical, but seeing people and being able to, talk about what's going on still remains a really important part of what we do. Endoscopy and colonoscopy is an interesting question. We are not doing any elective, I don't know if I'm sure different states have different rules, but New York, we are doing nothing elective. The only endoscopies we've done was actually for urgent procedures, some of our liver transplant patients, things that needed an urgent attention. And the key to that is going to be deciding at a society level what kind of protective equipment, personal protective equipment the physicians are going to be wearing, because we are dealing with upper endoscopy, there's secretions, we are dealing with colonoscopy, there's stool, the virus is in the stool as well. There's live virus in the stool. It's not just through respiratory. So I think what's going to change a lot more is going to be how we as physicians and those that are in the room are going to be wearing much different PPE than we were before, which was typically, some people wore face shields if it was a lot, if there were procedures that involved different procedures per se needed face shields. Otherwise, we were wearing gloves and a gown, right? A non-surgical isolation gown. That's going to look very different. So your next endoscopy is going to look very different for the physician. You'll be asleep in the same way, but it's definitely going to change on our end. And we actually have to create an implementation plan of how we slowly reintroduce endoscopy back in, knowing with all the social distancing, with all of the PPE, the room turnover, the terminal cleaning. I mean, it's going to be very disruptive, in the way we do it. It's going to take a while to get everybody. So basically we're trying to move elective procedures to, later in the summer, early before school, for example, and those who need to do it before the summer. And especially if it's not urgent, like just for me to want to do a scope to make sure that my drug is that the drug is working that I'm using, what we call that a treat to target scope. That may not be, you can maybe use stool markers, like calprotectin is an amazing non-invasive stool marker to tell me what's going on in the gut. We can use blood tests. There's other blood tests that a lab Prometheus is the same lab that we do a lot of our drug levels on. They have a blood test called the IBD monitor, and it correlates with endoscopy. So we should be using these non-invasive blood tests during this time to keep very, very tight control of patients, because we're not doing those routine, endoscopies to make sure that it's exactly healed the way we want it to, and whether or not we're making decisions on treatments based on scopes. With regarding infusions, as I noted before, it has been probably the biggest logistic burden or operational burden we've had to manage. And I think the bandwidth of changing insurance from an inpatient, from a hospital infusion to home, and then moving everybody back to the hospital infusion, I just think that no one's going to have the bandwidth for that. So I think that is also going to be changing who and how many people are going to be doing home infusions moving forward. The insurance companies wanted us to send people to home infusions. It's a lot less expensive. And of course, pediatric patients, we always want them to be monitored, and that's why we like infusion units. They know they know how to monitor pediatric patients, but we've had no choice. And we've literally deployed home health and infusion teams throughout the state and neighboring states. Our neighboring states were accepting our orders, even down south as South Carolina. I mean, people were scrambling to get prescriptions to people who left the city, for example, in New York before they couldn't leave. There was a lot of that exodus. So it's a lot. That is going to be also another burden. And so we're sort of gearing up for what everything, that will be like, and when will we ever, and if we will ever return to business as usual, as it was before.
Okay.
Yeah.
Well, that's really helpful. I think that people are really going to find this like extremely beneficial, like every single word that you said. I know people have been asking us, but also I heard from some of the healthcare team here that, there are people who are calling and saying, should I not be coming to do my infusion only because of being worried about going there? And they're saying that they're following all these protocols and they're very safe. So that was something that we just wanted to encourage people to not be concerned as much about that, the hospitals, the infusion centers are very safe. If you have to go, it's important not to miss infusion, as we discussed.
Yeah, I mean, let me even add more input on that, is that we as a global organization, this is the International Organization of IBD, we actually prefer that our patients are seen in an infusion center, exactly for the reason that you just said. The measures they're taking to screen patients, don't forget, there's oncology patients that are often getting infusions either in the room next door or very close. So the amount of precautions that go into screening at a hospital-based infusion center, because I can only talk about my own infusion center and what we're doing, than having necessarily a home nurse who may have been in multiple homes, one. But we've also partnered with our home infusion teams about their screening and their precautions. And so everyone's doing their best, right? Everyone. And the IOIBD did feel that we should be pushing for patients to stay at infusion centers. Obviously, New York is interesting because people come from many different states, right? You could be an hour away and live in Connecticut or Jersey. And there's a lot of logistics that goes into that. And there's people who drive 2 hours to have an infusion. And yes, I would like them to have it at my infusion center, but reality kicks in, and I'm not going to have someone drive in 2 hours when I could provide it at where an infusion site near them or at their home. So 100% support that. Please stay at your infusion centers, because after that, if you move out, it's going to be very hard to come back in. Just from insurance is going to say, why am I now going to pay for you to go to a hospital infusion when I've been paying like $500 compared to however much it is to pay for an academic center, right? In a hospital infusion center. So we're trying to tell people that stay as much as you can where you are so that we don't have to, if you never wanted home before, then don't want home now. But if you wanted home before, take advantage of the situation and we'll move you at home. It really is a case-by-case basis. If they've been COVID positive, they can't, right? And for us, you get your temperature checked. If your temperature is 100, you're not allowed in. So anyone who has any kind of anything that would render them driving and being turned away, we're keeping them at their house. So that's sort of been our protocols. But again, it is definitely recommended to stay at the infusion center if you can.
Okay. Thank you. I mean, I think that I know we went long, but I think people have really been asking us a lot of these questions. So I think people are really going to find it helpful. I had put on here something just about talking about IBD research in general and how is it going? And if it's still important to fund that and what's happening with that. If you could just speak briefly about that and then we'll be finished.
Sure, no problem. There's a lot of, efforts going on, particularly both looking at developing registries and understanding how patients with IBD and really looking at the impact of medications. That is extremely important for us. COVID's not going away May 15th in New York, right? Or anywhere. It's going to be here. And you hear a lot about what's going to happen in the fall. I would implore every single one of your viewers to get their flu shot the minute the flu shot comes out. Unless there is some absolute contraindication to getting the flu shot, this year more than ever, however you feel about vaccinations, and personally, it's almost like the understanding that to get flu and coronavirus, that's a big problem. And that is why it really is important that whoever is watching understands the importance of the flu shot in 2020. Okay, that is a really important point. Not just because of IBD, not because you're on any of these medications we've talked about, but the totality of if you are vulnerable or considered part of the vulnerable population, then getting the regular flu vaccine is going to be imperative. Similarly, in the future, as it relates to the coronavirus vaccine, of course, right? That's not even a question. I'm just saying that what we have now is the flu vaccine is imperative. And the antibody testing, which is another thing, Stace, that I think people should understand, is that when the labs have an accurate test to know who has been exposed, to confirm they've been exposed, so that we can understand what kind of therapeutic changes we may or may not have to make as we potentially face COVID until a vaccine, for example. I don't know if that's going to be true, but at least we think, as you've heard, that this is going to be a thing until we have a vaccine, we have better tracing, we know who's had it and who hasn't, and all that kind of good stuff. We need the antibody test to be both sensitive and specific. Not too many false negatives and not too many false positives. That's going to be very important for us to know. And I would say we just made a blanket statement with my team yesterday that we're going to get it on anybody who comes for labs or gets an infusion when the test is available sort of commercially and it's accurate enough. All IBD patients are going to be tested for COVID exposure. So they should get the antibody test to make sure we know what we're dealing with, right? So that you know what kind of measures need to go in. Probably one of the biggest research also ongoing is the role of genetics, and why is there some patients who are more vulnerable to the different types of COVID expression in different people, looking at genetics. And we've also taken biopsies of patients with COVID who we've done endoscopy, and we're looking at whether or not there's a specific signal on the cell that IBD patients may or may not have that may be protective for patients who are COVID positive. So there's a lot going on in trying to understand what is it about IBD, what is it about COVID and IBD, and how do our medicines and the different mechanism of action of these medicines, how do they either add risk or protection? And as of now, it looks like there's a huge protective effect of a lot of our medications because we're not seeing patients having severe COVID expression, especially in young patients, obviously. But that needs to happen because COVID's not going away, right? So that's why we need to continue to understand this disease and how it interacts in patients with IBD on different types of medications. So if anyone's interested in knowing what's going on in the different facilities, I'm happy to field. If you have people who reach out to you, just let me know, and I'm happy to give a laundry list of things that are being done.
Okay, yeah, great. There have been people who are interested in what the research is for, specifically for IBD and COVID. So we'll definitely connect you. And
Sure.
thank you
Yeah.
very much. This was really helpful.
Okay.
Thank you.
I think it really answered like a lot of people's questions and
Yeah, you're welcome.
beneficial to our community. Thank you.